welcome to UofL Today with Mark Hebert on Talk Radio 1080 WKJK and iHeartMedia in Louisville, Kentucky. This is the show, if you've heard it before, that is all about the University of Louisville and what's going on at UofL, including all the great stuff in research and what students are doing and our alumni and others. So, on the show today, toddlers who suffer head injuries. How many of them die before they reach 4 years old? We'll have a UofL researcher here to talk about that, as well as enhancing recovery for patients who have had spinal surgery. We'll also hear about UofL's Buddy Program for those with Parkinson's disease. But first, UofL has done extensive research on student behavior, what causes kids to be unruly, as well as the role those teachers play. Terry Scott is the director of the Center for Instructional Behavioral Research in UofL's College of Education and Human Development, and he's here to talk about his research. All right, well, let's just talk about what you do. What is the research that you do on kids in classrooms and behavior and those kinds of things?
Can we predict what kids' behaviors will be based upon what's going on in the school? And the quick answer to that is yes. We're pretty good at predicting that. And so we started trying to just take that down and take it down and drill it down. And we've really focused on teachers and instruction. So what we do is we go out and we sit in a classroom. We have a bunch of people that work on our projects that go sit in classrooms and they watch teachers. They have a little handheld device and they code what's the teacher doing, what's the kid doing. Pick a kid at random. So what we can say after doing this, we've done 13,000 of these, is that here's what the average kid is getting in class. Now what we do is we code as we're in there. Is the kid on task or off task?
And so is he paying attention or not?
Right. Is he engaged doing something with academics? And we also code, is the student having a disruptive behavior, anything that makes the teacher stop instruction and address the behavior. And so what we're finding is that we can predict those disruptive behaviors of kids based upon the degree to which teachers are using a couple of pretty simple strategies during instruction. So that's the good news.
Okay. So the good news is you can predict what they're going to do based on some of the things that the teacher is doing.
Right.
So let me extrapolate that out and ask the obvious question I think most parents would ask. So you're telling me that perhaps a kid that maybe struggles with behavior issues walks into a classroom, that you can figure out whether that kid is going to misbehave in that class before they ever do, based on what they're being taught in the classroom?
We can predict that.
Okay. Can't stop it.
So I can tell you this.
Okay.
If I go watch a teacher for 10 minutes, if the teacher I'm watching is using the most effective strategies, which we'll call active supervision, their head is up, they're looking at kids and talking to kids. 2, they're giving kids chances to talk back and do things and say things. What do you think? Show me this. And 3, they're saying, good, yes, they're using positive statements to kids. If the teacher I'm watching uses those things in the lower third of all teachers, the kids in that classroom are 27% more likely to be off task and 67% more likely to have a disruptive behavior. So while I wouldn't say those cause that, we certainly know they predict those kinds of behaviors. So again, the good news is we can predict it. The news that's not as good is that overall we find teachers use those 3 things in very low rates. We'd like to see 3 per minute, for instance, of
3 per minute doing what?
What we call opportunities to respond. Raise your hand if you agree. Turn to your neighbor, tell them what you think. Write that down and hold it up. We'd like to see 3 per minute during instruction, not all day.
More engaging.
Exactly. And what we see is far less than 1 per minute. So the things that the literature, the science out there tells us are really effective are things that we know do make an impact on kids. The challenge for us now is, how do we get adults to do these things? And I myself was a teacher, and so I've gone in and said, watch me today, I'm going to really crank these up. And you get in there and things get going and you forget and you get distracted. And so a lot of our challenge is, I think, how do we, at the School of Education at UofL, how do we train our teachers so that this is something they're practiced in and thinking about before they become a teacher? It has to be something that's ingrained and not something you just hear once.
Talking to Terry Scott, who's the director of the Center for Instructional and Behavioral Research in UofL's College of Education and Human Development. And we're talking about strategies and his research that he's done on student behavior in classrooms and how teachers can improve that behavior in classrooms. You also have found through your research that there's a disproportionate number of African American kids that are disruptive in class.
They're not disproportionately disruptive.
Okay.
Which is a really interesting point.
Okay.
They are disproportionately dealt with as if they are.
Gotcha.
So here's what we see. We code when we go in as the kid we're watching, white or non-white, and same with the teacher. Then we can go back and say, based upon just knowing the kid was white or non-white, does the teacher respond differently? And the answer is yes. So of course the first thing that everybody says is, well, that's because black kids have more problems. Well, we did this through a giant data set in JCPS, went into schools and looked at every teacher, watched kids, coded kids, and what we found is that behaviors of kids by age, by ethnicity, by gender are exactly the same. Kids are kids.
And it depends on how the teachers...
The teachers believe that some kids are more likely to have problems, and what they do is they actually have more negative interactions with those kids from the very moment they walk in the door.
Really?
It's not...
That's hard to... I mean, that's kind of hard to believe.
It doesn't matter the ethnicity of the teacher. If the teacher's black, we still get the same negativity toward the black students. What I think we're seeing is this, what we call implicit bias. Mm-hmm. So let's assume we know that that's not true, that they're more likely to have problems. But if I, in my brain, think that they are, what I'm thinking is I'm going to nip this in the bud. So I'm going to keep an eye on that kid, and as soon as they have a problem, bam, I'm going to get right on top of that. And there's a certain logic to that. What we're trying to get people to think is whether it's true or not that kid's likely to have problems really isn't important right now. If you think they are, then what are the things you could do when they first walk in the door that make it less likely they'd have the problem, rather than trying to get on top of them really quick, set them up for success. And good instruction is what really does that. And again, what we're finding is not just black kids, but kids with disabilities. And there's even some evidence that just being in a low-income school makes that happen too. Again, I think we have these preconceived notions of who might have a problem, and we treat them differently.
Mm-hmm. So, and it's dependent. I think what you're saying is far more dependent on teacher behavior and teacher instruction tools than it is on the kid and what they bring to the classroom.
And everybody wants to say that. Well, these kids come from horrible backgrounds. Well, et cetera, and they do. But again, we have no evidence that we can predict kid behaviors based on those things. The only evidence we've gotten that predicts kid behaviors is what adults are doing.
Mm-hmm. Talking again with Terry Scott from the College of Education and Human Development at the University of Louisville. So what is the bottom line here? You've done all this research. You've had, 13,000 observations in classrooms, something like that. What do you do with it? You said you're already trying to teach the students who are coming through UofL that want to be teachers that they need to change their habits or ingrain them with being more interactive with the kids in the classroom. But what do you do with the teachers that are already in JCPS that maybe have this implicit bias and are perhaps struggling with some kids in their classrooms?
And it's not just JCPS; it's everywhere
but I'm talking
we
about
go.
Local guys,
right? Yeah. And I don't think. And I really don't think, and I've talked to a lot of teachers, and I was a teacher myself, that anybody is out there thinking that I'm going to go and get those kids because they're bad kids. It's far more implicit than that.
I don't think anybody thinks that.
The key is changing adult behavior is far more difficult than changing kid behavior. And so what we have to do again is instead of, and I think we're making a mistake when we go in and say, you've got implicit bias, you're doing this wrong. I think instead we have to go in and say, these are some strategies we can use to make kids more successful. When kids are more successful, you're going to have more positive interactions. When you have more positive interactions, this thing's going to start turning in the other direction. So it's how do you greet kids at the door when they walk in? How do you say things to kids that are something that says something to them about, I care about you. What'd you do last night? How do you start the interaction positive rather than sitting back and waiting for something wrong to happen? Any kid in that room, if you stare at them for the whole period, you'll find something to say, knock it off about. And I think that's the wrong way to go about it.
Yeah. Last question then. So these, you said you're including these things in instruction at the University of Louisville and the College of Education. But again, what about the teachers that are already out there? Are there training programs that UofL is doing or are about to do to help JCPS and teachers in other school districts perhaps improve their strategies in dealing with kids in the classroom?
Yeah, we have a big new grant from the Kentucky Department of Ed that flows through the U.S. Department of Ed through Kentucky, and it's called Kentucky ABRI, which ABRI stands for Academic Behavior Response to Intervention. And we are creating videos that'll be on our ABRI website through the university that show how to do a lot of these things. We also have what will be set up as kind of like a phone bank. You can call in and say, I'm having a trouble with this kid doing this or that, and somebody will do a video chat with you and say, here are some things to try. And they might also say, go back and watch this video and this video, because they really show kids like you're talking about and how to do this. The other thing is that we have a new federal grant that's really focused on trying some strategies for, it's a kind of a counseling approach to dealing with teachers to try to set them up. And these are teachers that have volunteered, want to do this with us. And I'm doing this with Dr. Andy Fry and the Kent School of Social Work. And so we have a grant together that's going to be looking at using kind of a counseling approach and seeing if we can make inroads doing that.
This is just incredibly interesting stuff, incredibly interesting research here at the University of Louisville that you're doing, Terry. So I appreciate you being on the show. When babies and toddlers suffer head trauma, we know it can lead to long-term damage and learning disabilities. But how often do those injuries result in death? Beatrice Ugiliweneza is an assistant professor and also a researcher with the Kentucky Spinal Cord Injury Research Center. Beatrice, good to have you back on the program. Welcome back.
Thank you. I'm happy to be back here.
All right. We actually got two things we're going to try and plow through here in the next 11 or 12 minutes.
Yes.
Two studies that you have worked on. The first one involves head trauma to infants and toddlers. So tell me about that research that you did.
So we know from the literature that infants and toddlers experience their injuries present differently. So the infants have
When we're talking about infants, how old are infants?
So from birth to before 2 years old.
So birth to 2, and then toddlers are 2
to
to 5?
4. 2 to 4,
okay.
yeah. We defined it 2 to 4. Probably there are
Okay.
better definitions,
That's all right.
but that's what we used. And so we know that their injuries do not present the same, and the toddlers' injuries are more severe. So we assumed that because they're severe, they will lead to higher mortality, and we wanted to check that.
Okay. And what'd you find?
So we found that toddlers' injuries result in a rate of mortality that is double the ones of infants, 22% versus 10%.
So correct me if I'm wrong. So you're talking kids that are between the ages of 2 and 4
Yes.
suffer more head injuries and more significant head trauma injuries than babies, right?
Yes, their injuries are more severe, and they result in a higher mortality rate.
Why is that? Why do you think that that little kids are suffering more injuries, tougher head injuries, and are dying more than babies who you would think would have a softer skull and all those kinds of things would be more apt to suffer severe injury?
We don't have like a specific reason why, but we have leads to what that could be. And one of them is that probably they have been exposed to abuse before. And we have guide from the literature that if a kid is diagnosed with abusive head trauma, 30 to 75% likely they have been abused before. So they have a history of abuse. So that could be one reason. Another reason that we think is that these kids tend to be misdiagnosed because people don't suspect it. They suspect abusive.
They don't suspect that they've been abused. That they suspect maybe they fell and hit their head, or it was an accident.
Yeah, they suspect that it's an accident, so they don't treat it right, and they send them back to the abuse.
So they send them back into the home of the abuser, presumably.
Yes.
So that could cause it. Did these findings surprise you, and if so, why? What were you potentially surprised about when you looked at this data?
So I think what we were surprised about the most is that even the presentation of abusive head trauma in infants is seen with injuries and bleedings, fractures that you would think that are more likely to lead to mortality. And toddlers present with edema and internal injuries. So you will not suspect that will lead to higher mortality, but it doesn't.
Yeah.
Yeah. And again, it goes back to the fact that they probably have been abused before, probably.
Yeah. I'm going to throw this at you, and I have no idea if you know this number, but do you have any idea how many kids in the United States die each year from head trauma between the ages of birth and 4 years old? It's got to be thousands, isn't it?
Oh, I don't have the number.
No, that's all right. But is it thousands
yeah.
of kids? I assume.
Yes, it will be. Yes.
And most of them, I'm guessing, are from physical abuse, not from injuries that like they fell and hit their head on the swimming pool.
No. We actually
is it the other way around?
We actually made sure that we removed those unintentional injury, like they're not supervised right or gunshot wounds or. Those could be intentional too, but we made sure that they're not the ones that we're looking at. We made sure that we're looking at abusive head trauma, and we also compared to the traumatic brain injury, which is accidental, to actually see if that relationship of mortality and age is not just inherent to age. It's actually specific to abusive head trauma.
All right. So, Beatrice, if you got to wave a magic wand and take these numbers and your research and say, here's how we're going to solve this problem of these toddlers dying from head injuries at a greater rate than babies, what would you do?
I think more than anything, I would like for some maybe laws or specific recommendations to be made to healthcare providers and people who take care of abusive head trauma to be careful and look at kids who present to them when they're toddlers.
So take a second look at as you're diagnosing these kids.
Yes, take a second look. Yes,
and don't just assume that they were not abused. That it was
an
accident.
Yes, that it was an accident. Yes.
Okay. All right. Again, we're talking with Beatrice Ugiliweneza, and Ugiliweneza, I said it right the second time, who is an assistant professor and also a researcher with the Kentucky Spinal Cord Injury Research Center, which is based at the University of Louisville. All right. We said we were going to talk about two studies. The other one I want to talk about is the Enhanced Recovery After Surgery study, the ERA study. So what is Enhanced Recovery After Surgery? What is that? Tell me what it is.
So I'll go back and explain what happens when somebody undergoes surgery. When you undergo surgery, even though you're sleeping and you're under heavy pain medication, your body undergoes the same effect as if you were hit by a car, for example. So when you wake up, your body responds as such. So that's the surgical stress response. And the ERS is to try to reduce that surgical stress response.
Mm-hmm. And so it's been done on other really major surgeries.
Yes.
But you look specifically at people who had spinal surgery. What do they need to do to recover better, basically, is what you're mounting.
It has
amounts to.
Yes. So the ERS is actually a series of protocols, and the philosophy of those protocols is to try to help the patients have a better experience and recover faster. Mm-hmm. It has been implemented in a lot of major surgeries, but somehow in spinal surgery, it is slowly getting in there.
Took a while, huh?
Yes, it's taking a while, and there is no consensus yet.
Okay. But you looked at it to see, what could be some of these strategies that could be used in spinal surgery.
Yes,
all right. So what'd you find? If I know that I'm going to, or my doctor knows that I'm going to have surgery on my spine in a month or so, A, what should the patient do? And then B, what should the doctor do during surgery? And then we can talk about afterwards what should happen. What are some of those things?
I'm going to talk about what the providers should do, because that's probably what we try to do. We try to gather the literature on that. The few things that we have seen is to look at the patient before, to look at their like blood levels and sugar levels, and instead of only trying to do it afterwards, because if you know the profile of the patient, then you'll be able to manage it better.
But shouldn't patients quit smoking and do all the things that you're supposed to do to be healthy? And you want them as super healthy as they can possibly be if they're going into major surgery, right?
That is correct. Yeah, you want the patient to be as healthy as possible. Maybe even do some rehab pre-op rehabilitation or exercises so that it will be better to recover afterwards. Yes, that is correct.
And so what can the doctor do then, or the surgeon do, beforehand, and B, during surgery to produce these better outcomes for these patients where they recover quicker, cost less money, those kinds of things?
So pre-surgery, definitely screen and get the profile of the patient in terms of all their physiology. During surgery, try to use minimal invasive surgeries if it is possible.
We're getting more and more less invasive with the with the robotic surgeries and those kinds of things.
Yes, we're getting less and less, and less invasive, and that's better because the body responds obviously differently. You can think about if you're hit by a bus or hit by a football ball, your body's not going to react
a little bit different. Yeah.
So minimal invasive surgeries and open surgeries, your body will react differently. So the less invasive we can go, the better. The pain medicine that is used, to use the least possible.
So try and get off the opioids?
Opioids, short acting as opposed to long acting, and things like that.
And also anesthetic. Do these folks, anybody that has spinal surgery, do they get put under for a long time, or can you do local anesthetic?
Well, they're doing local more and more as much as possible. I mean, spine surgery.
Would you do local anesthetic if you were getting your spine operated out?
I don't know. I don't know, but maybe if they tell you that your outcome is gonna be better, you're gonna be less in the hospital, less complications, and walking, sooner, then maybe I'll consider it.
Beatrice Ugiliweneza, I appreciate you being on the show. Assistant
Thank
professor
you so much.
with the Kentucky Spinal Cord Injury Research Center. Thanks again for being on. The University of Louisville has a program to match first-year medical students with folks who have Parkinson's disease. It's called the Parkinson Disease Buddy Program. Denise Cumberland is an assistant professor in the Organizational Leadership and Learning Program, while Will Henry is a student in the UofL School of Medicine. So welcome to both of you.
Thank you, Mark.
Thank you.
All right, Denise, what's the Buddy Program? What's the Parkinson Buddy Program?
Oh, thanks for asking. Well, about 5 years ago, the Parkinson Support Center here in Kentuckiana partnered with the medical school and with the College of Education to initiate this intervention or experiential learning program where first-year medical students would be paired with a Parkinson's patient. So just think buddy. And over the course of 9 months, the buddies, we have a welcome party and everybody gets to know their buddy. We pair them up based on interests. And basically, the buddies are on their own. They can go out, and they often do go golf, or they go to an art museum, or they meet for dinner. Food is always a biggie. So there's a lot of eating that goes on. Typically, we've been studying this for, like I said, 4 years, and the buddies meet about 7 to 8 times through the 9 months. There are bowling events. We do group events, and all the buddies come. And the idea here is an experiential learning program for first-year medical students who don't get a lot of out there in the real world. So they get to have their own personal Parkinson's patient to talk to and get to know. And then the Parkinson's patient gets to have more socialization, opportunity to go out to, as some of the buddies say to me, young people energize you. And they feel like they're contributing back to the medical world by giving this student the understanding of this disease, because it's a complex disease that isn't easily spotted. So we think it's a great program. The results so far have demonstrated that. The students, like Will here, have really indicated not just enjoying the program, but really lifted their knowledge about the disease and their empathy for these people.
And so, Will Henry, you're what, a second-year medical student?
Just beginning my second year, yes.
All right, so you were a first-year medical student, and you participated in the Buddy Program. All right, well, tell me about it. What'd you do?
Well, so I became interested in the program. I guess my situation might be a little unique from other students. My grandfather was diagnosed with the disease, Parkinson's disease, about 1.5 years ago.
You had a personal interest in it.
So I had a personal interest, and at the time, it was a very newly diagnosed disease and very new to me in our family. And I thought this program would be an excellent way to delve more into the disease, see it firsthand, and see other people's experiences with it. I think that's so important as a physician to not only gather all the data and technology and treatments and all that, but also to see the kind of anecdotal side and see the personal side to the affliction.
So who is your buddy, if you don't mind saying?
My buddy, his first name was Jim.
Okay.
He's an excellent fella. We went out to dinner several times, went to the different bowling events and social events that the Parkinson Support Center put on, and just a great fella, very down to earth and very unique in his approach to the disease, or unique as I thought. But talking with my fellow students, I come to find out that these patients, they have such a great outlook on life. They're diagnosed with this lifelong disease, yet they're so happy to see you and so happy to live each day to the fullest.
Mm-hmm. We're talking with Will Henry, who's a second-year medical school student at the UofL School of Medicine, and Denise Cumberland, who's an assistant professor in the Organizational Leadership and Learning Program at UofL. And we're talking about the Buddy Program for Parkinson's patients, folks with Parkinson's. So Denise, what do you tell folks about this program when they ask you about it, about why you should do it? I think, and if I'm not mistaken, it's kind of a two-part question. Mm-hmm. Isn't UofL the only school that has something like this?
Well, actually, it is for the Parkinson's disease. This is a program that began many years ago for Alzheimer's. And so medical schools did this for Alzheimer's. And what we did was we looked at it and thought, wow, what if we replicated this with a different disease? And Parkinson's is something that is afflicting more people, particularly as we get older. So it's a disease that we're going to see double in the number of people who have it over the next 10 years. So as the population ages, we have more Parkinson's. So what we were hoping to do, the Parkinson Support Center and the medical school, was really to give an experiential learning opportunity that Will just described. And then from the standpoint of the patient, what happens with Parkinson's is people struggle with balance sometimes. You've probably seen that, or maybe know someone like Will has his grandfather. Maybe their face is a frozen face. Maybe they have a tremor. So sometimes they pull back on their social outings. So having something that encourages, we've had patients who participate who are in wheelchairs or on walkers. They still participate. Some of them are newly diagnosed and they want to just, basically try to, stay fresh. So joining, what we say to the patient is, or the PD patient is, that it's an opportunity to help the generation come up and be doctors who can diagnose the disease. They really do believe, and this is so critical, they're contributing by helping this medical student really identify this disease and learn how to talk to patients like they're real people, just as Will just described.
So that's what the folks with Parkinson's get out of it. Will, was that going to make you a better doctor?
Yeah, we were just talking before the show. I definitely think that it will. In the case of my grandfather, he went to 2 or 3 different neurologists with his symptoms, all of whom gave him different diagnoses, like an essential tremor or other things. And finally, his third neurologist came through and within 5 minutes said, "Oh, you have Parkinson's." It's all about knowing the symptoms, and I think it's a relatively rare disease in our society, and so I think for physicians of the future, it's very important to recognize those symptoms and get treatment early. The earlier you get treatment, the better the outcomes.
What's the going forward, the future of the Parkinson's Buddy Program at UofL?
Well, the good news is we just kicked off year 5. So I was over at the medical school with those first-year newbies that Will just is now in second year. But my colleague, Dr. Erica Branch, and Dr. Shaw and I were there to present to the first-year medical students and encourage interest. So we're pretty confident. We usually end up with about 25 applications from the medical school, and from the PD portion, we simply let the newsletter speak for us, and we have a lot of support groups. We talk it up. Usually we don't have any trouble getting 20 to 25 people involved on both sides. So year 5 is about to kick off.
All right. Denise Cumberland, Will Henry, good to see you. Thanks for being on the program. Good luck with the
you.
Buddy Program.
Thank you.
Thanks for listening to UofL Today with Mark Hebert, and Go Cards.